Um, Indeed, it's my great privilege to introduce Dr. Alok Gupta too, and he's going to talk on transition care for young person in diabetes, which is very important again. And he is a clinical director for pediatric department, Dartford and Graham's NHS Trust since 2015, and he has been working for child health for last 32 years, and he has secured a solid foundation of clinical experience and management strategies. Then he believes in his abilities for communication skills, broad-based clinical acumen, and he has always stressed on high standards of a clinical service in pediatric medicine and hospital management. With these few words, I introduce Dr. Alok and present to the august gathering. Thank you.
Let me share my screen. Good morning. Yes.
Alok, please share your screen.
Yeah, that's what I'm trying to do. Can you see?
Yes, yes, yes.
Yes.
And are they moving?
Yes.
Yes.
No, yes.
Oh, very good. Thank you. So before I start my talk, really, I'd like to extend my good morning from London and good evening to my colleagues across in India. And thanks to Bansi and Daycare Form team for inviting me for such an important topic, which is very close to my heart. And morning to my chairperson, Dr. Shukla, Dr. Jali, and Dr. Dalal. I don't have any conflict of interest for this talk, which is really good news. I'm going to spend 15 minutes or so on this talk, which is really quite important talk and topic for all of us. But perhaps it was not considered important topic for many, many years and decades because the diabetes in children and adults were looked after by adult physician or one team. So we hardly thought about it. There's a need or there's a change in that person's dynamics or lifestyle or various other issues. But lately, we are acknowledging that there's more and more reason for think about transition for that particular age, like 15 to 25, because the outcome is quite bad. Despite we are thinking about insulin pump, closure of loop, artificial pancreas, the data around that age group is very dim, very depressing actually. And this topic has been really close to my heart for many years because I started something in 2004, thinking about transition that time. But before we talk about really my experience and the data across the globe, what do we really know what is transition means? And the transition, I think the best definition described by Blum in 1993, the transition is a purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented health system. And this is still very valid. And really, we need to think about the future of the youth before we think about future of the nation. So really, again, this is very, very strong quote, I think, to make sure we keep in our practice in day-to-day life. And why really we feel that transitional care service is so important. And there are multiple reasons, and I'm going to describe a little bit some of them over here. Think about the increasing number of long-term chronic conditions in childhood, which we never really diagnosed before. There is increasing prevalence and recognition of these conditions in that age group, which is affecting our young adult. There is increasing morbidity, as Dr. Lee described. There are many coexistent health conditions which affect this particular age population, which obviously we need to look after. We acknowledge these are really important issues. I think we need to acknowledge in order to tackle, I think, healthy adult in the society. There are a lot of weight problems, and this particular age group population There's a lot of obesity and overweight problem. Now, because of all this region and there's no effective service in the country, clearly this age group population is staying much longer in children's services, which is really not very desirable because we are not equipped with all those expertise for young adult to adult in the children's clinic. We are really seeing a lot more acute and chronic complications. So we need to think about how do we prevent and manage these complications in this age. We noticed, I think, these group of population is not engaged, and there is significant decline in clinical attendance where we have a pre-booked appointment system, and up to around 60 to 70% population are not attending their healthcare professional appointment, which is very concerning. We know there's a lot of issue about the insulin adherence or treatment adherence issue in this group of population. Dr. Lee just described about the disordered eating. Around 35% of the population, especially female, they misuse the insulin treatment in order to maintain their body image and things. So that's really quite serious issue. We have a problem with a lot of behavioral issue, which predicts very adverse outcome in terms of HbA1c and overall diabetes outcome. We have seen young adults with a lot of psychiatric problems, again, very adversely affecting the outcome from the diabetes point of view. And the very dim data is about 60% of children only have a kind of arranged appointment to transfer their care to young adult clinics. And out of them, only 50% have appropriate healthcare professionals in those clinics. And this was discussed and planned. So very many reasons why we require transitional care service in any health system. And this is really important. Now, not to make you more depressed, but when we talk about DCCT trial, which is one of the gold standard trial in the history of diabetes, comparing intensive insulin therapy versus conventional, thinking about this will have similar effect in this age population. But interestingly, the young adult did not have any improvement in intensive insulin therapy regime arm, which is very depressing actually. And there's a lot of adverse outcome data, which is very, again, concerning. How do we really help? But then when they become adult, their HbA1c improves, regardless whether they are in intensive insulin therapy or they are in conventional. So there's something very peculiar about that age group between 15 to 25. And we know a lot of data is about the UK, and we know that there is a significant increase premature morbidity and mortality, and up to 3-fold in men and 6-fold in women, affecting age of 20 to 29. We know that under 30, a lot of mortality is because of diabetes, hypoglycemia, and DKA. So again, it's very, very clear difference between under 30 and over 30. There are a lot of, we're beginning to see the complications related to kidney, related to eyes, and even this age group population requiring treatment, which is very, very concerning because we hardly used to hear that a young diabetic will have complications of kidney and eyes. We think, I think it's a late onset disease of 40s and 50s, but that's not the case. A lot of issue about when I only described in terms of the follow-ups, but 30 as a healthcare service or system provider, we are not able to engage this group of population, and 30% of the patient at least miss their appointment once when they are given, I think, every 3-monthly appointment. 10% patients or more lost to follow-up. There's a lot of complexity about health service management, so these group of population find very difficult to really interact and coordinate their care. And many people, I think, felt, the process too abrupt without any preparation. And up to 40% of the population did not have any follow-up appointment in young adult or adult diabetes clinic, which is very, very concerning. I think there's an opinion that pediatric endocrinologists or diabetologists are very hesitant to facilitate this process because they don't have any confidence in adult diabetes team either. Again, there's a very clear difference between adult diabetes team and children's diabetes team, the way we function, and we want these children or young adult populations to come independently when they are not used to of coming to these clinics without their parents or carer. And as I just said, I think most of the time, I think the pediatric endocrinologist trying to delay the process because as we don't have a confidence in the system. Also, we need to think about, are we really trained to look after this age group population, especially for adult diabetes team, because they are not really have expertise and experience to dealing with this young adult population. So they try to treat them as like adult population as well. There's a lot of communications problems, and which really is being reported in some literature, either about the information or they've not been heard or parents didn't have a chance to talk about them. They compare, I think, the children's services like more informal, more family-centered, socially oriented, compared to where adult programs are more formal. And they really talk about long-term complications when this young adult are really not prepared about listening to long-term complications. So they get really completely switched off. We talk about transition a lot, but we hardly really study it as a proper formal randomized controlled trial. And a couple of studies are picked up from recent time, from 2017 to 2020. And they talked about really whether if we manage appointment more effectively, will that improve the engagement? And answer is no. If we provide a structured transition, does that improve? And answer is yes, it does improve clinic attendance, improve satisfaction, improve the distress. But this beneficial effect is not very long lasting. We have done a lot of work, I think, as a country in the United Kingdom, and we started doing national diabetes audit, and there's a couple of national diabetes audit. But again, very similar kind of theme where we have a concern there about completion care process. We got 8 completion care process, which clearly really get worse during transition time. Some of them they mention like annual blood pressure, cholesterol, retinopathy. They don't get worse, but clearly a lot of things get worse. So one of the important thing is really why we choose age of 16 to 19, because we found most favorable outcome when the transition happens between the age of 16 to 19. So just to keep in mind when we are trying to organize transitional care services, maybe this is the age we need to think about. Most of the really targets are achieved pre-transition, not the post-transition, and that's really concerning. But when you look at the DKA data, they get worse post-transition, which we know a lot of children or young adults, they come with recurrent DKA as soon as they go into transition or post-transition. It's exactly the same data which I just described, thinking about various care processes. In the light of time constraint, I would not go in detail here again. And then another really audit was done in 2017, published in 2019, again confirming similar findings. Here the annual care process, achievement of treatment targets, and DKA frequency get worse during transition. And there's a lot of variation in the service provision. So if you go to one unit to another unit, you will see a lot of variation. So there's guidance around it. What do we do, I think? And the most important thing is how do we work collaboratively with the young, like a children's team and the adult team from unit to unit, and learn from each other with the help of quality improvement projects to see what good practice they do. Very similar finding, but the interesting thing in this slide is once I think the deterioration starts, just in first year of transition, it does not improve for second and third year, which is really quite concerning. And as I said, I think if you look at the country, it looks like we are right. But when we think about individual units, there's a lot of large variation. But average becomes all right for the country, which is really not a true picture. What could be the ideal transition? Again, Blum described in 1993, which is really still valid. You need a multifaceted active process that attends to the medical, psychosocial, educational, and vocational needs of the adolescent when they are moving from that age group to become young adult. And this is still really the key thing. How do we work together, addressing all 3 or 4 domains of this particular age group? There's a lot of data being produced, and the guidance is produced in the UK, And this is a long list really, but despite all this, the state of affairs is not great, even in the UK. The National Institute of Clinical Excellence, we all know NICE, and produced the guidelines in 2004, and they revised in 2015. The important points here is we need to allow sufficient time. We need to have a local protocol and guidelines around this. We need to think about what is the best age to transfer, not the automatic transfer, not the set age. We need to think about relative stability when we transfer this care from a children's team to young adult team. And we need to really prepare this population by saying there would be some key changes in the service provision when you move from service A to service B. This is really quite interesting data from 29 studies with 16 systematic review, and they found these are the common good points. So process has to be centered around CYP, which is children and young people, has to be planned, has to be structured with some written roadmap. We have to have designated clinics where we have a really input from children's and adult diabetes team. We have to have a prepare this group for education and certain set skills. We have to have a transition coordinator. We have to have a MDT approach, multidisciplinary team approach, with the social and primary care involvement, because not just diabetes which affect this population. There's a lot of other issues around these age group which affects and influence the diabetes care. We need to have a good communications, and we need to have an ongoing training of healthcare professionals. I don't think we are really expert in dealing with this particular age group population, and we need to have the right resources to start this program and maintain this program. Another interesting really slide is about, we looked at in studies about different models of transitional care, and what they found that there are certain key elements about the different models, which is based on relational and longitudinal continuity, cultural continuity, management continuity, information continuity, developmental and flexible. And sometimes there's a trend between two continuity in terms of like flexible continuity would not allow developmental continuity to proceed. And unless you have a right proportion and right ingredients into any model, it would not really progress to become successful in transitional care. There's a lot of, again, diabetes, NHS diabetes quality care, they provided the standards, how to design your transitional care. Now I'm really going to rapidly share what we have done at Dartford in Kent area. So we acknowledged there is a need for this transitional care in 2004, which is almost like 16 years. But that time we started with transfer of care services, where we were offering 2 clinic appointments before we transfer child to young adult or young adult clinics. And this program was really addressed around age of 16 to 18. We created a 2 team, team A, team B, with a hybrid model, where a children's clinician will sit with the adult diabetes nurse. We didn't have a dietitian that time. We didn't have access to a clinical psychologist that time. But even with a little attempt, we have seen some improvement, and we managed to publish some data in SPET and shared in the conferences as well. So we did a 2 study. One was the qualitative one and one was the quantitative one, and both studies shows really favorable outcome in terms of patients and family were much more satisfied. Their attendance rate was much more improved compared to people who were not engaged in a transitional care program. We also looked at the quantitative data, and again in the early studies, we have seen improvement in their HbA1c and their attendance rate. The people who are engaged, they attended 100%, and their HbA1c improvement even when they started with higher HbA1c than people who were not engaged. And this was really encouraging, and this is with little attempt as a transfer of care, but in a planned, structured way. Now, recently in 2017, 2018, we really revised our transitional care services. Now we are hoping to provide, and we are providing proper transitional care services, which is really 3 years program. And obviously we are hoping the children or young adult will be ready by the time they go to young adult clinic. They have a structured program. Most of them, or should be on basal bolus program or CSII. They should be able to download their own data before the appointment and their day-to-day life. They should be really empowered and should be able to manage their own diabetes. They should have an annual review and completing 8 care process. And they should all have a individual care plan with individual HbA1c target. And this is a real proper MDT. As I described, we got an adult diabetes team, we got a children's diabetes team, we got a diabetes coordinator, we got a access to psychologists, we got dietitian, and we all sit together in one room. And before the clinic, we all sit together. During the clinic, we divide into 2 teams, as I described, where pediatrician sits with the adult diabetes nurse and adult dietitian, and vice versa. And they all are engaged with the annual retinal screening program. We are not just doing traditional clinics. We provide the workshop. We're still maintaining the school and home visits. We contact them 8 times in a year. And obviously, we send them reminder before the clinic appointment in order to improve their attendance rate in the clinic. And with this, in the UK, we got a best practice tariff. So we are claiming best practice tariff as an incentive. So the managers, really NHS managers, understands why we need to do all this. And within 6 months of this service, we could see that the number of encounters with this group of population has gone from 3 to 12, which is extraordinary. We started seeing the improvement in the attendance rate, which was really 30% DNA rate did not attend, which has come down to 21, I think, which is really even better than 21 now. We started beginning to see the improvement in the HbA1c. A majority of patients started displaying sign of improvement in their HbA1c. We did not have any decay or admission with severe hypoglycemia within that 6 months of study from the start of the service. And we had a lot of positive comments from the young adult population, but also with their parents. And this is absolutely brilliant, I think, and encouraging to the local team. So really, in summary, we can say this is a really active process. This is not something we can be very laid back or we can neglect or ignore. It has to be young person centered. This has to be, I think, family oriented, not just patient as a patient. We have to prepare. We start preparation around the age of 14, but real transfer happens between age of 16 to 19. We need to be adaptive and resilient, multidisciplinary, multi-team, multi-agency work. And I think it has to be age appropriate, developmentally appropriate. I described the 5 key or 6 key, I think, continuity thing. We need to make sure we bring really right proportion. We need to have our own training. I don't think we are trained enough to look after this particular age group of population. And I think at the end of the day, we need to really impart and transfer these skills and independence to this particular age group population. And eventually to make sure we get maximum potential. There are a lot of documents internationally, nationally, locally produced. I think here is the list. I think if you would like to look at it. And but obviously it's a very complex topic. It can be boring topic, especially with the people who are completely disengaged or unengaged, to engage them back into the system. But it's one of the key areas. Without this, I think you can't really make a successful diabetes care and healthy population in any nation or globally. Thank you. Thank you for listening.